pleasure and an honor to contribute also this year to the Congress of the Forum of Anesthesiologists and Reanimatologists of Russia. I'm sorry not to be there in physical and in presence and to meet my good friends and a lot of colleagues I've been in touch over a long period of time. And I hope that in the next future we will have the opportunity to meet again and to share some time together. Today I will present on how to bring brain protection, cerebral protection into the practice, into the everyday practice in patients undergoing non-brain surgery, and what we can do as anesthesiologists to minimize the possible perioperative threat of the brain damage. We will see some of the evidence related to the epidemiology of perioperative cerebral damage, and we will go through some of the possible mechanisms of the pathophysiology of perioperative brain damage, and we will see and review together some of the don't do and some of the do. The epidemiology of postoperative cerebral damage. Originally, the first evidence of adverse cerebral effect of anesthesia and surgery. I want to remind that it's not only anesthesia itself that causes the perioperative brain damage, but also the inflammation and the anemia and the stress related to the peri-procedural course. So the first case was described in 1955 by Bedford, and he reports how an elderly patient undergone general anesthesia had a substantial deterioration of his neuropsychological and cognitive abilities. And so he concludes saying he has never been the same after the operation. This is something that we should avoid, which is the evidence related to overt postoperative brain damage. We know that after non-brain and non-cardiac anesthesia, the rate of new neurological deficit is relatively rare, 4 cases every 10,000 patients, but in some subspecialty, the rate of new neurological deficit are much higher, as after obstetric procedures, after carotid procedures, brain and cardiac cases, and so on. On top of new neurological deficit, we should also consider the postoperative cognitive dysfunction. That is a little bit more subtle change in the ability of the patient to communicate or to elaborate their cognitive or emotional state. And it's important to know that at 3 months follow-up after general anesthesia, a dedicated test can detect some level of persistent cognitive dysfunction up to in approximately 10% of the patients. Another form of postoperative cognitive dysfunction is postoperative delirium. And postoperative delirium is relatively common. I would rather say between 5 and 15% after general anesthesia, but in some subset between 50 and 70%. We know that these figures were also confirmed by a seminal paper published in the last decade of the last century. And it's interesting to remind that at 1 week postoperative follow-up cognitive testing can detect some level of reduced abilities in about 25% of the patients. So these are some of the risk factors for postoperative delirium and postoperative cognitive dysfunction. It's important to know that preoperative cognitive impairment is an established risk factor. Abnormalities of the plasma sodium concentration, dehydration, but also excessive depth of anesthesia, and high bleeding in perioperative course, as well as postoperative pain and other risk factors. So it is important to remember that patients undergone general anesthesia do have a higher risk of global cognitive decline. So there is a relationship between general anesthesia and surgery and an increased risk for cognitive dysfunction. Notable in 2018, a consensus conference proposed to rephrase and rename the so-called postoperative cognitive dysfunction, POCD, as delayed neurocognitive recovery. This wording has not been implemented extensively in the literature, but the recommendation is to use this wording to describe a persistent neurocognitive dysfunction. Pathophysiological mechanism. There are some recognized pathophysiological mechanisms, and periprocedural arterial hypertension is one of the major predictors. And despite there are no correlation with cardiac or cerebrovascular events, it is important to know that arterial hypertension below 55 millimeters of mercury of mean arterial pressure might associate with an increased risk for cognitive dysfunction. Periprocedural anemia is another risk factor, and it is important to consider a threshold value of 12 or 13 grams per deciliter, respectively, in female and males, that associate with an increased risk for postoperative delirium and longer in-hospital stay. So perioperative anemia is a frequent and relevant risk factor. Excess of oxygen. This is important. I mean, oxygen is vital. And we all know that there's a specific competence of anesthesiologists to deliver an adequate fraction of oxygen and to warrant an adequate partial pressure of oxygen. But too much of oxygen might induce an excess of neuronal biomarker release and might ultimately lead to some form of brain damage. Another element that we can impact is the excess of ventilation. So hypocarbia or hypocapnia was described as a cause of delayed reaction time as back as in 1968, when patients exposed to extensive hyperventilation, I would say, with a PaCO2 below 24 millimeters of mercury, showed, when compared to normocapnic control, a prolonged reaction time up to 7 days after anesthesia. This correlation, the relationship between hyperventilation and hypocapnia and the risk of cerebral event, namely the occurrence of postoperative delirium, was also confirmed more recently in 2017 with a study that used periprocedural perfusional MRI and showed how patients showing an extensive vasoconstriction due to hyperventilation are at higher risk for postoperative delirium. It is well known and well established how cerebral emboli, especially occurring during extracorporeal circulation or carotid surgery, can associate with an increased risk for periprocedural cognitive impairment, but also the use of anesthetics, and some of the evidence report an increased impact of intravenous, other report an increased impact of inhalational. Certainly, both intravenous and inhalational do cause a brain inflammatory reaction with some release of S100 beta protein that is specifically associated with neuronal death. This is an interesting study that compared the impact of general anesthesia versus local regional anesthesia on postoperative cognitive dysfunction at 7 days and 3 months follow-up. It's notable that in both of this population, there is an increase in postoperative cognitive dysfunction that complicates approximately 5 to 7% of the studied cases at 7 days follow-up, and of about 10 to 20% at 3 months follow-up. But notable, when the analysis is performed as per protocol, so how the patients were actually treated, the difference turns into be significant. In patients undergone extracorporeal shockwave lithotripsy under spinal anesthesia showed a more significant risk of postoperative cognitive dysfunction at 3 months follow-up. So spinal anesthesia, eventually because of the risk of associated hypertension, arterial hypotension, might induce or might associate with even a higher risk of cognitive dysfunction. What can we do in practice? Which are the means that we can bring into the operating room to minimize this risk? Unfortunately, evidence regarding brain monitoring so long have not produced conclusive evidence on a possible benefit. So the use of brain monitoring has not shown to associate with an increased course. But there are other, similarly, there is no benefit on specific drugs. So this is a paper published 10 years ago. We reviewed randomized clinical trials on pharmacological periprocedural neuroprotection. 17 drugs were tested, but actually no one showed a clear benefit. So the idea of infusing propofol instead of thiopental or benzodiazepine to protect the brain is just a tale, but there are no clear evidence on the beneficial effect of pharmacological neuroprotection. Are there other approaches that have been tested? These include the use of steroids. There's a metazone in this randomized study was tested in approximately 300 patients, but no differences were detected. Another element that we should strictly avoid is the use of colloids whenever possible, the dilutive effect on hemoglobin, and eventually the associated effects, especially of the isostarch, might generate paradox effect with an increased risk for postoperative delirium. Is there something we can do? This study, the use of periprocedural dobutamine low dose in elderly patients undergoing hip arthroplasty showed a positive impact on the cognitive function measured with the mini mental state on the 7th postoperative day. And this is probably due to a better brain perfusion. So good blood pressure, adequate red blood cells, a good delivery of oxygen, not too much, are effective measure. Another important and effective manner to improve or minimize, let's say, the potential risk related to periprocedural anesthesia and surgery impact on neurocognitive function is prehabilitation. This is a systematic review and meta-analysis that consistently show how prehabilitation effectively associate with better cognitive course after surgery. And this study further goes in details showing how we can elicit good results in the various phases of the procedure: preoperative, prehabilitation, exercise, nutrition, and reduce the fasting. It's clear that fasting time should be reduced with a light meal 6 hours before surgery and allowing the patient to drink up to 2 hours before the procedure. Also, preoperative carbohydrate preload 2 hours before surgery has been shown to associate with a better course also in the cognitive function. Intraoperatively, not too much of ventilation, both in terms of minute volume, so do not hyperventilate, keep the PaCO2 normal, not too much of oxygen, avoid propofol, and excessive anesthesia depth. Avoid also to use, whenever possible, periprocedural colloids. In the postoperative course, similarly, the quiet environment with a good control of post-procedural pain and normal glycemia and arterial values with early mobilization are effective measures that associate with a favorable cognitive course. So there are several aspects that we can consider regarding the possible interaction of drugs and other procedures. You can see down there the effect of too much of ventilation, of hypothermia, hypoglycemia, or hypocarbia. In conclusion, postoperative cerebral damage can complicate the clinical course with conditions that have different severity and persistent, like stroke with new neurological deficit, an acceleration of chronic cognitive dysfunction as in Alzheimer's disease, delayed neurocognitive recovery, what is formerly known as postoperative cognitive delirium and dysfunction, and postoperative delirium. There are several possible underlying pathophysiological mechanisms. The most important are arterial hypertension, anemia, hyperventilation, too much of oxygen that also induce neuronal inflammation and microemboli. There are several do not. No benefit in direct neuromonitoring so long, no benefit in using steroids, and certainly avoid starch and colloids in general unless specifically needed. There are some do. Prevent hypoperfusion. Effective peripheral perfusion is the best way to protect the brain. Optimize the ventilation, not too much and not too little of oxygen, not too much of hyperventilation inducing hypocarbia. Prehabilitation and dedicated perioperative workup is very effective along with ERAS principle and might contribute to substantial positive course. Thank you so much for your attention. It's my pleasure, and I look forward to the next time I'm going to meet you in person.